to the right atrium where the central venous pressure is 0 to 8. And then it comes into the right ventricle, which is a pumping chamber that has to pump blood through the whole lung system. So our PA pressure, our right ventricular pressure, ranges 15 to 25 over 8 to 15. Okay? Then, by the time blood goes through the lungs, that pressure has decreased. It comes back in, and left atrial pressure ranges 4 to 10. Okay? What we would call the wedge pressure. And then, when it gets into the main pumping chamber of the heart, the left ventricle, which is a thick muscular structure, the main pumping chamber of the heart, that's where that systolic blood pressure is generated up to 120, and then once the ventricle ejects and the ventricle relaxes, then diastolic pressure is less than 10. Okay? But this is where the action occurs. This is where the pressure comes from, is from the left ventricle. This is important, and I know this was this was easy for you, but this is important because we kind of have a set of principles about pressure. All right. So mean arterial pressure in the post-op hearts. Okay, this is our write down. Mean arterial pressure. We want mean arterial pressure to be 65 to 85. Okay. 65 to 85. All right. Now, there's some qualifiers here. If the patient has aortic stenosis, all right, where the ventricle is thickened and the ventricle doesn't relax well because compliance is diminished, that's called, just so you know, that's called diastolic dysfunction. And if you let the mean arterial pressure go low in a patient with aortic stenosis, they can develop what we refer to as a nutcracker ventricle, and where the ventricle ejects the blood, but it won't relax because it doesn't have pressure against it. Okay, so then the ventricle, then heart rate goes up, cardiac output comes down, the ventricle looks like it's squeezing 100%, but instead of squeezing 70 cc's of blood with every beat, it's only squeezing 15 because it doesn't relax. It doesn't have diastolic relaxation. That's why it's called diastolic dysfunction. That's why if the patient comes back into the hospital, that's called diastolic congestive heart failure. Okay? So now you have an understanding of ventricular compliance, diastolic dysfunction, and the difference between systolic congestive heart failure and diastolic congestive heart failure. We call it diastolic congestive heart failure. For example, in the patient who has chronic hypertension, they can get this big, thick ventricle, and the ventricle doesn't relax. And they come in short of breath because all this blood that's coming back from the lungs is all backed up in their lungs. All right? So diastolic dysfunction produces diastolic congestive heart failure. Okay? A bad ventricle that's had a big heart attack and the ventricle's not moving well, that ventricle doesn't have enough force to eject blood well. It can't establish a good pressure to get blood out to the body. That's systolic congestive heart failure. Okay? Due to a failing ventricle. So that's a big difference now. We want you to understand systole or systolic heart failure versus diastolic heart failure, because the therapies are dramatically different. All right? But the principle is a mean arterial pressure 65 to 85. Okay? Then we want a cardiac index. Does everybody know what cardiac index is? Cardiac output divided by body mass index. Yeah.
Body surface area.
BSA, correct. Okay, we want a cardiac index ideally 2.2 or greater. Okay? At a minimum, 2.0. Okay, why? Because sensitive organs that don't have a cardiac index of greater than 2.0 will deteriorate. What's that number one organ? Kidneys, okay? So, it's not the brain, okay? It's the kidneys, all right? And we start losing kidneys if the cardiac index is less than 2.0. So a minimum of 2.0, and to give us a margin of error, we say 2.2, all right? So how do we maintain a mean arterial pressure of 65 to 85 and a cardiac index of 2.0? We need to know the filling status of the right side of the heart and the left side of the heart, okay? So, for example, at IMED, 100% of heart surgery patients have a Swan. And we know what the wedge pressure is. At Utah Valley, about 15% of our patients have a Swan. Okay, we don't use Swans. We use non-invasive monitoring. What's it called?
Hemisphere of the Acumen.
Acumen. And we use the CVP. Okay, what's the normal CVP? 0 to 8. All right, we have identified that there are two parameters for management. If the CVP is higher than 15 or the CVP is lower than 15. This is on the majority of open heart patients. If the patient is hypotensive and they have a CVP greater than 15, we generally assume that their volume status is good. The problem is their ventricle. That's the patient that needs an inotrope. Okay? If they're hypotensive and the CVP is less than 15, and we know what their ventricle is, because we use echo on 100% of our patients in the operating room. So when we come upstairs, we know how the ventricle is doing, all right? If it's less than 15, then we give volume, okay? So it's pretty simple, and it's understandable, and it physiologically makes sense, okay? So if the patient's hypotensive and the CVP is less than 15, we give volume. If the patient's hypotensive and the CVP is greater than 15, and remember this depends a little bit on how long they've had disease, whether it's valve disease or ischemic disease. If the PA pressures are sky high, then this doesn't work so well, all right? It's gonna take more pressure. We might have to say this needs to be 22. But for most of our patients, 15 is a good cutoff. So volume. Okay, now we're going down a whole nother rabbit hole. What's volume? The heart surgery service, we like 5% albumin. Okay? It's expensive, we know it. All right? We've been around the block with pharmacy on this. We've been around the block with the system. We still like 5% albumin. Our orders, patients get 1,500 cc's of albumin, and then we switch to saline after that. We are the only place that does that. All three of the other programs use normal saline, okay? And, but albumin is still better. Is there data to say that? No, believe it or not, we really don't have strong data in that regard. But I think we give less volume with albumin, okay? And that's because it's more osmotic. It stays in the blood vessel longer, okay? So we use albumin.
Fast.
What?
Fast.
Fat.
Fast, quick.
That's a good point. How do we give boluses? So first of all, we don't do continuous drips, all right? We don't have normal saline going at 75 cc's an hour. We have normal saline going at 15, sometimes 30. I think it's 30. But it's just for TKO. We give volume quickly. We want to see a quick response. So it's 250 cc's over not more than 5 minutes, okay? And it's all bolus. We don't like seeing boluses on the pumps. Use the bowl, okay? If the surgeon is standing there, tell the surgeon, hey, squeeze this. Give us something to do, all right? We want the volume in, all right? So 5-minute
Your
boluses.
name is Lena Candy.
Okay, we like the boluses to be on the squeeze thing, not on the pump, all right?
The hand pump.
What's that?
And
We just call it the hand.
Yep.
Hand blood
pump, okay.
pump.
What about blood?
Same thing.
All right. We have a very strong blood conservation program that went through the whole ATP Advanced Training Program process, if you're familiar with that, years ago. We do not use a trigger for transfusions, all right? IMED, it's a cookbook. If the hemoglobin is less than 7, you get blood, okay? If, and you get more blood depending on what the operation was, all right? We don't have a hard number. If it's 7, we start thinking about it. If it's 6, we're all pretty solid on 6 unless the patient had a low hemoglobin to start with. And if we took him to the operating room with a hemoglobin of 8, then we may not even transfuse at 6, okay? But if you get a hemoglobin that comes back at 7, we need to know. That's another number, okay? Because we need to start thinking about blood, all right? But everywhere else, that number is 8. And we in our cabbage population, we transfuse about 9% of our patients. Nationally, the cabbage population has a 45% transfusion rate. That's straight out of the STS. We are super low, okay? But we let our patients go down to a very low level. But that means they don't have any lactic acidosis. That means they got a good cardiac output. That means their heart rate is less than 100. It's not 120 or 150, okay? So it depends on the whole picture of the patient. If their heart rate's 120, they're hypotensive, the hemoglobin is 6.5, and you're pouring fluid in them to try and get the cardiac output up, call us and we will transfuse the patient. Yeah. All right. So now, okay. So now on to the next. How do we support the hemodynamics? There are a number of inotropic agents, and we have chosen as a group to minimize the ones that we choose to use based on how successful they are in management. Let's just go down the list. So the vasodilators, nitride, we don't have available. So we don't use nitride anymore. Okay, we haven't used nitride for
Not for
Oh,
probably
years.
5 years.
Yeah.
never even heard of it.
Nitroprusside it's just a different formulation of nitroglycerin. It's like a long acting. The benefit of nitride is that it's both a venodilator and an arterial dilator, okay? It's good after load reduction, especially for patients with pulmonary hypertension, okay? But it's not patented, and the companies that made nitride don't want to make it anymore because they don't make any money, all right? What are you doing?
I'm videotaping.
I
you.
see that. Number 2.
I might not ever get you here again.
Nitroglycerin. Okay, nitroglycerin is primarily a venodilator. So it decreases central venous pressure. It decreases right ventricular pressure. Because the blood is not getting back to the heart, it's decreasing preload. Okay? Then we have milrinone. Okay? Milrinone, adenylate cyclase inhibitor. It is it's both an inotrope, it helps the ventricle to squeeze, but it's also an afterload reducer. Milrinone does not improve blood pressure. It decreases blood pressure. That's super important for you to understand. Often the staff asks for milrinone to improve the blood pressure. Okay, boom, right there. You recognize they don't know what they're asking for, okay? So then we have the true inotropes, and those include epi, norepi, dopamine, dobutamine, isoproterenol. We as a program essentially only use now norepinephrine and epinephrine. We don't use any more dobutamine because it generates tachycardia. A lot of conflict on this. The heart failure docs like dobutamine. There's a patient up on the 5th floor on a continuous dobutamine drip right now. It has a definite role in the chronic heart failure patient that we have not seen to be beneficial in the acute heart failure patient that's undergoing heart surgery, okay? We use 2 inotropes, epi and norepi, all right? And there's a difference between those 2. Epi is a strong chronotrope. It increases heart rate as well as increasing myocardial contractility, okay? Heart rate is not necessarily a good thing. Increased chronotropy increases oxygen demand. So, you know, we opened up a whole nother window. What's the goals here? The goal is maximizing oxygen demand. Trying to use as little oxygen and get the best squeeze that we can get, okay? A fast heart rate uses a lot of oxygen. This will be important when we talk about a pacemaker, okay? So norepinephrine is not as chronotropic, okay? It has good, but not great, improvement in contractility, but it's more of a peripheral vasopressor. Okay, so we use it for blood pressure. We use it to some extent for ventricular squeeze. All right? So now, does the patient have a good ventricle or a bad ventricle? If the ventricle is good and the patient is hypotensive because they've been on pump for 6 hours, we will often use norepinephrine, Levofit. If the ventricle is bad and the patient has a low blood pressure, we will often use epi. All right? And then, if there's not success, then we will add another chronotrope, noninone. So that is generally our protocol. We use 4 drugs. We use nitroglycerin for afterload reduction, milrinone for afterload reduction and inotropy, norepinephrine for vasopressor and to a lesser extent inotropy, and epi for inotropy. Okay? And that's how we do it. Now, there is still conflict in the data about epi versus norepi. There is one complication associated with epi, which is very clear. Does anybody know what that is? Well, tachycardia.
Tachycardia.
Okay. Acidosis is the other
Oh,
one.
yeah.
Okay. Epi causes peripheral shunting. So lactate goes up. Okay? Lactic acidosis. So we got to be careful with that. That's when we start following lactates and pH more closely, things like that. All right? So our protocol does not allow our nursing staff to start a chronotrope or an inotrope unless it's ordered. All right? So if you have those concerns, you have to call us. What we are going to ask you is, what's the heart rate? What's the CVP? What's the cardiac output? Okay? And we can provide our recommendations knowing the ventricular function on that patient, which you guys may not know, I mean, unless you look up the echo report. And then we'll go through those 4 medications primarily. We rarely use dopamine. We never use dobutamine in our program.
When would you use dopamine?
So dopamine is similar to epi, okay? It's more similar to epi than it is to norepi. So dopamine at 0 to 3 mics per kilo per minute is almost a little bit of a vasodilator, a little bit of an inotrope, okay? But it's also a chronotrope. makes heart rate go up. Dopamine in higher doses, it's a chronotrope, but then it becomes a real inotrope, we just don't use it. Yeah, we don't use dopamine and dopamine. Almost, I can't even tell you when. Okay. All right. Okay,
Okay.
so now we.
Do you want to tell them about Nitro and Clevaprex? Because
Yeah, nitro and clofidipine. That's
Yeah.
a very good point. So a couple little, well, let's talk about clofidipine, which is a IV calcium channel blocker, and nitroglycerin. Our protocol is that you can go to a max dose of 200 mics per minute on the nitroglycerin. Okay,
some of the orders still say 300.
our orders say 200.
Some
No,
say
some
three.
orders say
Mm-mm,
300.
some orders say
Most
300.
orders
Perfect.
say-
Mine this week.
300 then, okay? We like nitroglycerin. Why do we like nitroglycerin? Because when we do bypass surgery, we use a mammary artery as one of our bypasses, and in 70% of our cases, we use a radial artery, and it decreases spasm, okay? Nitroglycerin is good. I thought it was 200, so I apologize for that. I did not know that. I thought it was.
Well, it seems, I don't know. Do they all say 300?
No,
So
it
there was a
depends who
time where it
puts
was
it in.
like 200, some say 200, some say 300.
So they're
The
still,
last couple months I've only known it was 300.
Well, I came in a couple days ago and Mr. Chapman was on like 280, and I was like, ooh, that's pretty aggressive.
hey, it says 300.
300. I'm game for that because the alternative IV medication in our hospital is clofidipine, an IV calcium channel blocker. Calcium channel blockers in general are very good medicines at lowering blood pressure on the arterial side. They're afterload reducers, okay? They're not as powerful of a spasm preventer as nitroglycerin, all right? But clofidipine specifically causes a shunt in the lungs, all right? Where blood that's coming into the lung comes out of the lung still deoxygenated, all right? That's the downside to clofidipine, is that it causes shunting in the lung.
Is that because it's a dilator?
Blood's going through faster, it doesn't get oxygenated. I don't know the physiologic reason, okay? But a patient who's got a low, their oxygen saturations are low, you will lower their oxygen saturations more by putting them on clofidipine, okay? So, you also have, I think all three of us will agree on this, that we are trying to get away from clofidipine specifically. That's why we added hydralazine to the orders, okay? Hydralazine is an alpha blocker. It is directly intended to manage arterial hypertension of the artery, not the vein. And
How much of hydralazine?
so, how do you dose hydralazine?
10 every hour is the
You
last
do-
order.
Yeah, it's all on the order. You will tank a patient with that, okay? 10 milligrams IV over 1 minute, wait 20 minutes and give a second dose. It's not 20 milligrams all at once, okay? They'll tank on that too. And then that can be repeated Q1 hour up to 4 hours.
The orders we've seen is only 10 every hour. We
Yeah.
don't have the follow-up 10 after 20 minutes.
So is that just like if you're in the
Well, there you go,
room
that's
with
20 milligrams. Over
No, we
20
don't, we've never seen the 10
Oh, you
after.
us? No.
That's not how the order's written? Okay. So the conservative order is then 10 milligrams IV over 1 minute every hour. There is a max dose of hydralazine a day. And I don't know what the max is.
I can look it up.
I don't think it's 200, it's
Well, I
it's
said
some
this
number
on
less
this.
than that. All right? The morning of post-op day 1. All right? Okay, before we leave this,
200 milligrams a day.
so it is 200 milligrams, so that's the max dose of hydralazine a day is 200 milligrams. So you do have to be conscious of a max dose. Don't be afraid of using hydralazine. It's a very good blood pressure medication, okay? The problem with hydralazine is we don't have a good oral form of hydralazine, okay? We have clonidine, and clonidine makes people not feel good, all right? But it will lower blood pressure, so stay on it. Now, if we just can't get the blood pressure down, and most of us say, so that's a good question, what's hypertension? Generally, we want that blood pressure to be less than 130 on just about all of our patients, except maybe the aortic stenosis patient, where we'll let it go up to 145, okay? For the CABG patients, for sure, we don't want their blood pressure to be greater than 130. For the bleeding patient, we don't want their blood pressure to be less than, or to be greater than 100. Okay, until they stop bleeding.
If you're Dr. McCann, you want your MAP 65 to 66.
Yes, McCann likes a
One
lower
number.
blood pressure.
You get one number.
And, yeah, you do.
65 to 66. That's
Okay,
it.
all right. He's not teaching the class. So, McCann likes a lower blood pressure. I don't understand it, but he does. You have to perfuse the brain, okay? You have to perfuse the kidneys. Such a point. So, the point is, use your hydralazine. I like hydralazine better than clofidipine. Now, we keep going back and forth about clofidipine and another medicine called nicardipine. We don't have nicardipine, or at least it's like scarce. And nicardipine supposedly has less pulmonary shunting than clofidipine. Okay? So a couple nuances when we talk about drugs. Use generic names. Okay? We get into a lot of trouble even with nurses who don't know brand names from generic names. Learn to use generic names. We all know generic names, okay? I'm just trying to think of a, Milrinone is, what's the brand name for Milrinone? I don't know.
It's
I can't
It
even
doesn't
remember
It's
it.
really weird.
But propofol, that's another one. We all know what propofol is. You can use the term propofol. Call it propofol though. Don't call it prop. Okay. It's just it's a thing for people who use the terminology all the time. Levo, Epi, those are okay. And those. But it's a general thing that if you know the name of the drug, then you know what the drug does. That's kind of what's important about it. People memorize those abbreviated names, but then sometimes they don't know what it is that they're talking about. Okay? So if you know the whole name of the drug, then you usually know what the drug is. Okay. I want to talk a little bit about what affects hemodynamics. So remember, it's a 1-to-1, it's 2 pumps with a 1-to-1 ratio, but it has to go through variations in the blood pressure to achieve that 1-to-1 ratio. And there are anomalies, illnesses that can affect how blood flows through the heart. So each of the 4 valves